Um, Good afternoon, everyone. Welcome to the second series of the Gender Mainstreaming and Social Inclusion webinar series with ISEC Consulting. I'm pleased to have an excellent group of panelists with us today. I'm going to briefly introduce them and then leave it up to them to introduce themselves. So today we're having an exciting team who are going to talk about different things. They're going to talk about their experiences on working on sexual and reproductive health with the UN, and that will be led by Mr. Niyi Ojuolape. And then we're also going to have experts from the London School of Hygiene and Tropical Medicine, as well as from King's College London, sort of go through their experiences working in humanitarian settings, especially mainstreaming gender and social inclusion. Then we're going to have Deborah Delgado. I hope I pronounced your name well, properly, Deborah. Yes. She's going to talk about her experiences working on climate change and conservation in the Amazon basin. And we are going to have Dr. Annie Hoops, a consultant pediatrician working with Kaiser Permanente, talk about her experiences on adolescent sexual health. I'm going to do a very quick presentation to sort of run you through their topics and expertise, and then I will let Mr. Niyi Ojuolape start with his presentation. I'm just going to quickly do that. Okay, great. So, this webinar series started from and we noticed at ISEC Consulting that a lot of interventions were being done in different fields. And though you had a response, you had different academic institutions and also UN organizations asking for gender mainstreaming. This was specifically in certain components of health intervention. And we thought it would be useful to bring together learnings across different thematic expertise and to sort of talk up more about social inclusion and intersectionality. And these are just a few to give you an idea of several things ISEC Consulting works on. A few slides, which I will quickly speed through. So we work on gender mainstreaming and analysis, inclusive education, health system strengthening, gender-based violence, conservation and climate change, and development. And one of our key goals is to sort of provide evidence base for ensuring gender mainstreaming, social inclusion, and health system strengthening and development in low and middle income. So you probably might have attended our previous webinars, but if you haven't, for this webinar, we're going to be, some of our speakers are going to be Mr. Niyi Ojuolape, who is UNFPA's resident representative in Ghana, Dr. Nii Hassan, who is the co-director of the Health and Humanitarian Crisis Center and an assistant professor at the London School of Hygiene and Tropical Medicine. We have Ms. Kristen Mega, who is at King's College London and works on the research for health and conflict in the Middle East. Dr. Deborah Delgado Pogli, who is an associate at ISEC Consulting and principal investigator and assistant professor at the Pontifical Universidad Católica del Peru. And then we have Dr. Andrea Hoops, who is a consultant pediatrician based at Kaiser Permanente. Now I'm going to quickly go through their backgrounds and profiles, but I will also let them introduce themselves. So Dr. Niyi is currently the UNFPA's resident representative in Ghana. He's also worked at United Nations UNFPA's chief of staff at the headquarters in New York. He was also a former special assistant to the executive director at UNFPA in New York. Before joining UNFPA, Mr. Ojuolape served with the Nigerian government in different capacities, including as a special assistant to the Minister of Health and the chief program officer for donor coordination for the Nigerian National Agency for the control of AIDS. Mr. Ojuolape holds a Bachelor of Science degree in Banking and Finance. Sorry, I skipped that. And as well as an MBA. The second speaker, Dr. Niyi Ojuolape, is the co-director of the Health and Humanitarian Crisis Center, as I said before, and she has a diverse background in public health with expertise in health policy and systems research. Niyi also led a commentary piece, which we'll be talking about, which sort of shared some of her findings on intersectionality, mainstreaming gender, and intersectionality in responses. COVID-19 responses in humanitarian settings. She regularly works with several UN and international organizations and governments, and she's a technical advisor to the World Health Organization. Christine, a colleague of Niyi Ojuolape, also worked with her in the commentary piece they'll be talking about. She works at King's College London in the Conflict and Health Research Group. He also leads a Women's Leaders in Health and Conflict initiative, which sits within these programs. Christian has also started her PhD at King's College London, which investigates the role of women's leadership and participation in health system strengthening in northern Syria. Prior to working at King's, Kirsten has also worked with the New Zealand government, the International Organization for Migration, and NGOs in Australia. Dr. Deborah Delgado is a principal researcher and assistant professor at the Pontifical Universidad Católica del Peru. She has extensive experience as a consultant and researcher in environmental governance and climate policy. She also recently won a grant to work with indigenous women in the Amazon basin and to sort of see what their responses are during the COVID-19 pandemic. She has also been involved in a lot of policy advocacy processes, and she has followed the UNFCCC processes as a multi-skilled agenda. Dr. Andrea Annie Hoops is a board-certified pediatric consultant, adolescent medicine physician. She practices with the Adolescent Center at Kaiser Permanente. She is also a researcher and conducts several research projects on adolescent health. She has participated in clinical and policy level advocacy efforts to improve health services and sexual health education for adolescents in the United States and in low middle income countries. She has also done some work for the World Health Organization. So we are very excited. We're very excited to have this team of experts, and now I am going to let them lead, starting with Mr. Niyi Ojuolape, who's going to talk about some of his experiences mainstreaming gender and social inclusion in Ghana. Thank you.
Thank you very much, Doctor. Let me share my screen. How do I share screen? Yeah. Okay. Let me first do a sound check to see if you can hear me, Doctor.
Yes, I can hear you.
Okay.
Great. Thank you.
Let me do F5. Okay. So the topic is mainstreaming gender and social inclusion in COVID-19 responses, and we have a very, very unique case in Ghana. Not particularly unique, but then it's unique in the sense that with which the government took the response at the beginning. Now, the introduction, by way of introduction, I would say the pandemic, it's a global pandemic, and as everybody knows, it came along. Apart from the health implications, there were also very, very serious socio-economic implications everywhere, not just in Ghana. But for us, we look at it, we see it for those of us in UNFPA, United Nations Population Fund, by the way, if I may, we are very, very interested, in the issues of gender and in gendered implications of anything that happens within the country. And so when the pandemic hit, we were looking out for the implications as to gender in terms of from the gender lens. And so we had the first case in March 2020, and thereafter the government came into the arena to respond very, very positively to the issue of the pandemic. And government actually brought in $100 million to invest in combating the pandemic. So every aspect of the health sector requirements was taken care of. There was testing provided. There were several other things that government took care of in terms of treatment, isolation centers, health sector workers, personal protective equipment, and everything. Government made sure to provide everything. But we in UNFPA, we noticed a gap in the response. And that is the socioeconomic response to the pandemic, which we saw had a gap in the gendered implications. What is the implication for women? What is the implication for gender equality? What is the implication for gender equity? We noticed all that. And now we can see, I can tell you that when we noticed that, we came into the arena to bridge this gap. And over time, you can say that the president has shown a manifest interest in all that is happening. I can say probably that will be the only president in the world that has addressed the nation. Solid addresses for 17 times since the pandemic hit. And government put a lot of money, and there was also a lot of facilities that was put into it. Now, what does the coronavirus? What is the implication of the coronavirus pandemic on the populace? It has several negative effects. You will see that it had the extreme poverty. There are people in extreme poverty, but then it has also increased the number of people in extreme poverty by 9.1%. The coronavirus pandemic also has caused 65% of this increase as a result of the fact that we had lockdowns in the country, in the society. Also, we have excuse me. We have confirmed cases, credible data that shows that savings of 30% of the population will vanish as a result of the pandemic. Now, what does this mean in particular for vulnerable women and girls? Those, the effects of the pandemic on the general populace, that is already well known. But then for us, if we look at it, what does it mean in particular for women and girls? First, there will be deepening gender inequalities, and that was noticed right from the beginning. Secondly, is the fact that because there is little or no social security or protection within the country, the poor suffer more. So we have the women, they suffer more, the poor suffer more. So you can take it from there that the poor women are actually at the bottom of the ladder, and they are the ones that will have the COVID-19 pandemic affected the most. And thirdly, which is the third part, which is very, very important, which also accentuates the first two, is the issue of sexual and gender-based violence and poor reproductive health outcomes. Those are facts that are staring us in the face, which anybody, if you just take a somber look at the pandemic's effect, you will see that these are very, very important issues that that needs to be tackled. But resources and attention was not coming adequately from government to look after it. And so for us in UNFPA, we got involved in the COVID-19 response by looking after this particular issue. So, and we decided that in line with the UN mandate, which is to build back better, we got involved. And then, what are the measures that we took in order to tackle the issue of sexual and gender-based violence and the gender implications of the pandemic? First, we had to go to town to let everybody understand that there is the issue of domestic violence, because as soon as the virus hit, a couple of weeks after the president, the government had to lock down the country to say everybody should stay in their homes. And if you see, for those who are living with aggressive partners already, or those whose intimate partners are domestic violence perpetrators, that increases their risk, and also that puts them in more danger. And so the first thing we did was to ensure that we created an advertisement, a publicity campaign to talk about the possibility of domestic violence and the implications of domestic violence, and to let people to understand that in cases whereby you have domestic violence, what are the things that you can do while being locked down in the same space as your aggressor. So we established the domestic violence hotline. We now call it helpline. The domestic violence hotline, with which people should be able to make a call, and when you make a call, there will be some form of either help or some form of response from the special police unit that looks after the issue of domestic violence. In Ghana, that unit is called DOVSU, that is Domestic Violence and Victim Support Unit. So we activated that helpline, and 24/7, and calls were coming in, reporting cases, and we're able to respond to those cases by transferring them to DOVSU, and DOVSU they did their best in reaching out to those that are involved. That is the first thing that we did. But secondly, like I said, we went to town. Going to town means that you need to get people to understand what their choices are concerning sexual and gender-based violence and domestic violence. And in order for the publicity to get enough traction, we did a multimedia campaign, which included bringing in people, social media influencers, not just social media influencers, but influencers in the society, those who have a large following on the internet, on Instagram and what have you, so that the word can be spread around. So we engaged actors, we engaged actresses, artists, musical artists, and what have you, and we use them. We use what they have we use their platforms, their Facebook, Instagram platforms, Twitter platforms, to send out messages to say something like, if your partner is aggressing you, or if you are facing domestic violence in any form, please call this DOVSU number. Help will come your way. And it actually had a lot of traction, because all over the country, people got to know that they had choices when such things happen. And the third prong of that multimedia campaign was that we sent out text messages. We sent out text messages to individuals generally. We sent out about 1 million mobile phone users, so that they have the information about what they can do, and also how to call the helpline, for them to understand that gender-based violence should not be accepted in the society. And that gained traction. We got a lot of responses. And so the next thing we did, as you will see, is that we had several, because nobody could go out. We had captive audiences in the houses. So we had several e-workshops, virtual workshops, to talk about the issues that are involved around sexual and gender-based violence generally, and to also bring on board several other people that will add value to the campaign. Another major thing that we did was we already have within Ghana, we already have some shelters for women. That is where women can shelter when they are with abusers and they realize that their lives are in danger. So we had some shelters which were in a state that needed some renovation. So we rapidly moved into it to renovate those shelters, so that people can be able to take advantage of it. Also, we used to have with our colleagues in the UN, colleagues in IOM, they have the human trafficking shelter, which is for those who are being human trafficked. So we also talk to them, and with the government, with the Ministry of Gender, for us to have their shelters repaired and being ready to take on those who might need it at the end of the day. And the other things that we did, the other interventions that we in UNFPA that we carried out, was to provide what we call dignity kits. Dignity kits, basic essential items that a woman, usually a woman will need to be able to maintain her dignity in any circumstances. So you have this pack that includes washing soap, bathing soap, a towel, toothpaste, sanitary pads, and just basic things, a box of pomade, and certain things that everybody will need in order to live a life of dignity. I mean, on a typical day, just the most basic. Actually, for us in UNFPA, this is what we actually provide in humanitarian conditions and in war situations generally. But then the situation in which we were as at that time was that women who are generally vulnerable needed that, because they are not those women. Their subsistence, the vulnerable women that we targeted are such that they live on a day-to-day basis. They live on what they get per day. And during that time, during the time of the lockdown, during which they will not be able to earn any living, we have to parachute this across to them. But we gave them dignity kits, not just to serve as handouts, really, but really to use that as an entry point in order to give them reproductive health education that will enable them to carry out actions that will enable them to maintain their dignity, and also to understand what they can do in cases whereby problems arises, problems that has to do with sexual and gender-based violence. So we gave them, and we also went to isolation centers. We also gave out dignity kits to them. We searched out people living with HIV, people with disabilities, and even some people who are in Boston institutions. We reached out to them with hygiene products. You see, we also ensured that talking about the issue of COVID-19, that it included hand sanitizers, it included soap, toiletries, and basic things, and face masks, so that while maintaining their dignity, they can also do their best to ensure that they are not that they don't come into contact with the virus. Now there is a set of most vulnerable women in Ghana, which are called the KIAs. The KIAs are the head porters. You usually find them in markets. So if somebody goes to the market, buys his or her stuff, you have these people who come around you to say, I will help you to carry your stuff from where you have bought it to where your car is. So they help people like that, and so they get pittance from those who they help. And so there are, and those who are among these, the chief among these sets of people in Ghana, which we call the Kai, they actually migrated from the north, came into urban centers to try and eke out a living. So they are vulnerable, and most of them, they don't have shelters. Believe me, they don't have shelters. They don't have where they stay. They actually sleep outside in the elements, and they don't have shelter. They are very poor, and so by virtue of that, they are vulnerable to all sorts of things. They are vulnerable to gender-based violence. They are vulnerable to rape. They're also vulnerable to sexually transmitted infections. So these are a particularly catchment set of people. So that particular cohort, we knew that we had to reach out to them, because they are also vulnerable to unintended pregnancies, especially if for most of them that are actually illiterate, and so they needed reproductive health education to get them to understand that because you see them, their children, they are also carrying children. That means that they actually had unwanted children, so they carried unwanted pregnancy. So we needed to reach out to them to stem the tide of teenage pregnancies, which is very, very rife among them. So the period of the COVID-19 also enabled us to get them as a captive audience, to give them reproductive health education so that they can do what they need to do. Now, one other thing that we did, as you can see from my presentation, is that we have a group of young people within UNFPA Ghana, and their networks also. So we did door-to-door campaign, taking along the commodities, contraceptives, condoms, and what have you, and also the domestic violence pamphlets and information booklets, to give it out to people and answer their questions and respond to their needs. And in doing this, so yearly fellows and the interns, they went out and we were able to reach thousands of families just by that door-to-door campaign. Now, I've told you about the KIAs. We instituted, as a result of COVID-19, and even this actually started after the period of the lockdown, we instituted a program which we call CASPRO. CASPRO is a KIA assistance project. So we started this project and we got a cohort of 500 young ladies, because most of them are actually adolescents. 500 young ladies, we brought them together in order to respond to the risks and vulnerabilities that they face as a result of the issues of dignity, theft of their sales, harassment, rape, sexually transmitted infections. They also engage in unsafe abortions and unintended pregnancies, which came out of it, and all sorts of things, and also HIV. And so, so we decided to focus on them and attend to them. So what we did, which we call connecting the dots, was to find a way in which we'll respond, we'll give them what they need. That is the basic things that they require in order to, and we use that as an entry point to give them reproductive health education. We give them essential relief items, the dignity kits that I mentioned, that I described much earlier. We also give them sexual and reproductive health education and information on services. When we enroll them in a mentoring program whereby they get mentored by individuals in the society. And then, very importantly, we will not let them just go away like that. We have what we call the entrepreneurship and income generating activities, in which we teach them, we give them basic vocational training about what to do, beads making. So they took, whatever they are comfortable with. Some of them are now making pastries, some of them are making doing beads, some of them are doing weaving and what have you. Then very importantly, we must also note this, because in doing this, if you give them food, we don't have shelter to give them. If you give them food, you give them mentoring, you give them entrepreneurship and vocational training. We also needed to guarantee their health. Therefore, we enroll them on the National Health Insurance Scheme so that they can have access to health. So basic opportunistic infections and what have you that comes, they are able to take care of it. And so we have found it very, 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 very wonderful, because the results that have come out of this, the people who are involved over time, they've matured, especially based on the reproductive health education that we gave them. So what are the lessons learned? What pointers can be taken from our approach? You will see that our approaches are actually community-centered and they are solution-driven by even the beneficiaries themselves. We have also learned that the use of digital platforms during the period of COVID-19 have proved very, very useful in reaching very large groups of people. And we have also realized that another lesson is that the awareness creation and education programs are best received in local languages. When people have it in their local language, in their mother tongue, they are more likely to understand and take it on board and use it. And their interventions also, our interventions also show that you should leave target beneficiaries empowered and not even more dependent. So when you give them the handouts, you should find a way to make them to be able to fish rather than just taking fish from you. And we also find out lastly that interventions and activities should be tailored to specific target groups, so that your interventions are tailor-made, and we should note that no one size can fit all. So I want to thank you very much for your audience. I'll be able to take any questions whenever you want me to. Thank you very much, Doctor.